I'm speaking from Brazil, and today we have our international VMR. So we are very excited to see you here, and we need a case presenter for today. So I'm going to say in Portuguese. Bem-vindos a todos. So Gerline, do you want to say hi?
Hi, everyone. I'm Gerline. Thank you so much for joining us today on this Saturday. There's a lot going on in the world with COVID in different places, so I'm sure everyone's been affected. So thanks for spending this Saturday with us. And I'm looking forward to learning and reflecting with you all. And I'll pass it on to Sukriti.
हाय एवरीवन नमस्ते मेरा नाम सुकृति है मैं इंडिया से हूँ which translates into my name is Sukriti as you probably guessed and like Gurleen I'm really happy that I get to spend this 1 hour with all of you and I'm looking forward to chatting with everybody and learning all the different languages in the chat. And my favorite part of Saturday VMR is listening to the problem representations in the different languages. So super excited, and I'll pass it on to Rafa.
Hi everyone. Like Gerling said, like we're in this middle of these crazy times, and I just hope that everyone is safe, including their family. Sorry, and I personally have been dealt with COVID before. We're dealing with now. Just to share my experience, like 1 week before my step one, my parents got sick with COVID, and it was like this very, very bad experience for me because at the same time I was doing my U-word questions. I heard my parents coughing and getting sick, and there were no beds here in Brazil as well. So this community gave me strength and hope to keep going. So I'm really thankful for this opportunity to be with you guys around, and thankfully my parents are okay now. And I just hope that we can give you the same hope and the same strength that I took it from this community the time that I need it. So maybe I can pass the mic to Kara.
Hey friends, hey Raf, I'm so sorry to hear that, but you did very great, so I'm happy for you. So hi friends, I'm Kara from Peru, medical student too. Well, I just say hola in hi for is hi in Spanish. And just to second what Rafa said, is hard times right now, but hopefully I think this like a magic hour where I don't think about problems and I see happy faces here discussing cases, and this magic hour. I love being here with you, and I hope we have a case so we can have fun.
أهلا وسهلا. أنا اسمي ربيع, which means in Arabic, hello, my name is Rabi. It's a delight to see you all. There's a big cloud over many parts of the world today, for many different reasons. A torrential downpour in South America with COVID, torrential downpour in India, and with COVID, and then many other issues across the world. And yet here we are, Spanish, Portuguese, Hindi, Arabic, and many other languages. Let's nerd out, y'all. And we're going to nerd out today with a friend who has told me about a case a while ago, and I've been in eager anticipation of Preeti presenting to us today. So Preeti, please unmute yourself, introduce yourself to the VR family. But before you do that, I will invite everybody to remember that we would love for you to hear, we would love the people who listen to this, who are more than the people who are able to join, to hear your voice. So please, please, please participate in the chat, and we'd love to call on you if you unmute yourself. And so it'll be a conversation of hopefully 43 different people. Everybody has something to say. So I really, really encourage you to try to get your voice out there, because all of us have knowledge to impart, and all of us are part of this community. But with that in mind, Preeti, please take it away. Say hello.
Hello, everyone. Yeah, I had an examination, so I missed a few session of this VMR. So I'm glad that I'm back. And yes, I'm Preeti Agarwala. I'm basically from Bangladesh, but right now I live in the US. And hope to have a good discussion today.
Hello, hello. So Preeti, can you tell us how you say good morning in your native language? Oh, I think you're muted, my friend.
Oh, I'm sorry. So
No?
yeah, it is Shuprabhat. That is good morning. It is similar to Hindi, I guess. Uh,
Suprabhat.
yeah, it's a
Wow.
small, pretty word.
And
Yeah.
what do you, and the language is called Bangla, right? Is that how it's pronounced?
Yes, Bangla or Bengali.
Bangla or Bengali? And how, where are you located now?
I live in Iowa.
In Iowa. And how old were you when you left Bangladesh?
Okay, so it has been 3 years.
Sure.
Last years. Yeah, I've been living here.
What do you miss most about being home?
The food.
Yeah, good.
Because there are not many good Bangladeshi restaurant in the US.
Yeah.
Yeah, unlike Indian food. So yeah, I miss Bangladeshi food a
What's
lot.
like what's Bangladeshi food like?
So Bangladeshi food, it is similar to the Indian food, I would say, but several things are different. Like we use we eat the leafy vegetables a lot. In
Interesting.
Yes, the green leafy vegetables, so which is not very common here. So I miss them a lot, a variety of green leafy vegetables. And we also use those mashed vegetables with spices, with rice. So that's called bhorta, the mashed vegetable. Yeah, so that's a very important thing of our meal. So I miss them a lot.
Incredible. Thank you so much for sharing all that. You made Rabani hungry.
I'm feeling hungry as well.
Yeah, incredible. All right. Well, final reminder to the chat. Please, 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 if you are here, say something. We'd love to hear your voice. But in the meantime, we'll take over the screen and hear Preeti's first aliquot. All right, Preeti, we're ready for you.
Yeah. Okay. So this is a case I discussed with my supervisor in the clinic. So it was an interesting case. So I'd like to discuss that. So the chief complaint, I would say, 72 years old female came to the clinic with the history of crampy abdominal pain for last 5 days, and she also had a raised temperature of 101 degree Fahrenheit. She told us that the temperature usually gets worse at night, usually. And she also had this she felt fatigue for last 2 months and occasional headache.
Incredible.
Yeah. And so actually this was the chief complaint.
Yeah.
Not Yeah.
This is a great place to stop. I think a really, really good place to stop. And I'm curious if anyone has any thoughts from the chat. I'll pause for a moment to see if anyone wants to reflect from the chat. So if you have some reflections, please share them in the chat, and we'll ask you to share them out loud. There we go. Yeah, Sandra, what are you thinking?
Can everyone see me? Okay. Hi, miss everyone. Nice to see you. So I think the basic, when we are facing, we have a patient, we always have to take into consideration the age. 72, it's an age already that I start looking more carefully. Female, at this age, females tend to have more diseases that before they were protected, sometimes for hormonal reason and things like that. Crampy abdominal pain. So unfortunately, he doesn't specify where exactly. The abdominal, I'm just assuming at this point that is general abdominal pain.
Yeah.
But it's in abdominal pain, it's important to know the location. It can guide us a lot. 5 days, it's something new until this point that we know. Abdominal pain with fever, it's a concern for me. It's very a concern, and it could be many things. Abdominal pain can be a lot of things. But when it comes to abdominal pain with fever, I would look for infection especially, but also because of her age, I would even start thinking in something malignant that's starting to manifest. So what I would look for, she has fatigue for about 2 months and occasional headache. It's too general, it's not anything specific though, so it could be anything. So I would look for, I want to know if there is bleeding associated, if there is a bleeding, if it's upper or lower gastrointestinal, even if it's just not gastrointestinal, if it's related, if it's linked to symptoms in other systems. I would look for, the location. I would look for masses. And I would investigate more about the onset, if it's really 5 days or, because sometimes at the beginning, patients start talking, but when you start doing a more conducted questions, they can give you more information. And if there is a diarrhea or not, or even constipation, I would say look for the stools. If there is associated more systemic symptoms, it's saying fatigue, but it's very general there. So if there is any weight loss associated, anorexia, things like that. There is because it's too general, there's many things that I can keep going on talking. But I would say, I would say that I would start with that. So let's see. Yeah.
I love it. I think Raquel is picking up on some themes that you started. I'll pass the mic to Raquel. Please introduce yourself. And you were making a lot of connections with what Sandra was saying out loud, as eloquently as she always does. But tell us.
Thank you. What are you eating? I'm just curious.
Yogurt.
Okay, it was between yogurt or ice cream, but I was maybe. Yeah, okay.
Only yogurt.
Okay, so I'm turning over to Raquel. Thank you so much.
Raquel, introduce yourself, please. No, it's okay. You don't need a camera. Just unmute yourself. It's okay. Are you able to unmute, Raquel? We love to hear your voice.
She may be otherwise occupied, Robbie.
Yeah.
I saw that. Yeah. Good job. I'm so sorry. No worries. Thank you, Drew. I saw her very early on. Gurbani mentioned IMAID and the 3 Gs. Gurbani, tell us more.
Okay, so IMAID is because of fever. I translate that per Ravi's teaching to inflammation. So think about infection, malignancy, autoimmune, drugs, and endocrinopathies. So, I mean, similarly, I think I also learned from you that with abdominal pain, you want imaging to help localize, because it's really difficult just from, I don't know, just like physical exam or otherwise to tell what's going on. I think another thing I'm thinking about is is this patient have a surgical abdomen, or are they stable enough, it's not an emergent situation? So like thinking about like signs like peritonitis. And then in terms of the 3 Gs, you also taught me that. So with abdominal pain in a female-bodied individual, think about GI causes, which you can kind of take like an anatomical approach for. So thinking kind of like left upper quadrant, maybe like a splenic abscess or diverticulitis or colitis. Right upper quadrant, you think more about like hepatitis, hepatic abscess, cholecystitis, or cholangitis. If you're in like the left lower quadrant, again, diverticulitis, colitis, pyelo, PID, renal abscesses, and then for right lower quadrant, think classically about like appendicitis, again, PID, diverticulitis, colitis, pyelo, renal abscesses. Suprapubic, you can think about like endometriosis or like cysts, and then periumbilical, more like pancreatic abscess or early appendicitis. And then if it's more like diffuse, yeah, I think want to probably get like some more sampling to get more idea for GI-GU and then GYN stuff.
I absolutely love that. Nothing to add. I saw that a couple other people had some thoughts too. And Rosa, unmute yourself and tell us more, please.
Hello, sorry. I'm just a high school student, so I'm just like listening to y'all.
Oh, that's so cool. Wait, tell us more about yourself.
I'm based in London and currently in year 12. I'm 17. So yeah, just really cool discussions.
In medicine, like how did that come about in high school? That's awesome.
Oh yeah, I'm really interested in medicine and I always am reading like scientific journals and stuff. That's how I yeah, I just suggested bacterial infection because that's probably could be a reason. So yeah, that's pretty much it. Sorry, thank you.
No, can I tell you something before you go? Please don't unmute yourself yet. One is I'm going to slow down with you because I imagine that if I were a high school student called on at a conference that involved people across the world, I'd be nervous as heck.
Yeah.
But I'm going to tell you that I'm going to slow down with you and tell you that it's unbelievable that you are here and that your interest in medicine is so strong that you're hopping onto this conference as a high school student. So an incredible journey that you are on, and kudos to you for I think everyone literally the CP Solvers team is on my screen right now and they're stunned by the presence of yourself on this call. So kudos to you. You're clearly doing something very right. And thank you for joining us, really. And I hope to see you. Your thought about a bacterial infection is tremendous, not just because it comes from someone with the amount of training that you've had, which is much less than most on the call, but also because it's so spot on. That's really the focus that we have in medicine. A life-threatening bacterial infection is one of the most common causes of crampy abdominal pain and fever, as Gurbani was saying. That's one of all the G's, really, GI or GU or GYN, are sources for possible bacterial infections. So kudos to you. And thank you for sharing.
Thank you so much.
Of course. And keep participating. Now, I don't hide away now that you said something, okay?
Sure.
And I also saw, so I have to scroll real back up because there's a lot of comments for you in the chat, my friend. I also saw another really interesting comment from Teeb. So Teeb, do you want to unmute yourself and tell us more about, you were kind of trying to get more history, but please introduce yourself and tell us what questions you were wondering about.
Hi, good morning and good evening for some other people. I'm Deep Sulaiman. I am a medical resident BGY3 from Qatar, Hamad Medical Corporation.
أهلا وسهلا.
هلا فيك، كيف حالك؟
حال كيفك أنت؟
الحمد لله. Actually, it is my first time to participate and it's my pleasure to join this nice family. It seems a very interesting case. Actually, this combination of abdominal pain and fever, this has a very wide differential diagnosis. We can either distribute the differential diagnosis based on the area, like upper quadrant, left quadrant, or all the 4 quadrants, or we can distribute the differential based on the duration. I think we are dealing with the acute symptoms of 5 days of abdominal pain and fever. But what's concerning here is the fatigue for 2 months. Are we dealing with like chronic conditions and now we have acute insult over this?
Beautiful.
I can list more than 10 or 15 differential diagnoses. I think we need further information in the history before labs, like history of for example, does the patient has history of IBD before?
Beautiful.
Does the patient has history of TB, contact TB before, or like she has diarrhea or constipations, melena, vomiting, etc., etc. I think after further information, I can narrow the differential diagnosis.
Excellent, excellent. So well said. I have nothing to add to your analysis. Very well said. Rafa, you had some thoughts about imaging. Tell us more.
Oh, it's actually something that you always teaches us. Like when it comes to abdominal pain, we must rely on imaging. There's just a few exceptions that we can diagnose someone with abdominal pain. For example, if we see elevated lipase, we could think about pancreatitis. If we see a rash, we could think about zoster. If we see on the physical exam a hernia, we could think about hernias. And if we see, like, for example, someone with type 1 diabetes and with ketonuria, we could think about GKA and so on. So thank you.
Excellent. And our focus has been so much on the abdominal pain, but I saw Gabby snuck in a thought about the headache. Gabby, teach us more.
Yeah, I was looking to the headache. So I think what's important to know is we have to decide if this is a primary or a secondary headache. Primary headache was, as I said, is migraine, tension type, and trigeminal autonomic headaches and the other headaches. And secondary headaches are headaches that are being caused by something. So what I think this person has some red flags for headache in this case, because he is having a headache that is worse at night. It's the temperature. Yeah, so he's having fever. He's older, so he's 72 years old. So this is also something that we have to pay attention on. And he has systemic symptoms, which is both the fever and the crampy abdominal pain. So we have to pay attention to those things because we have to decide if we're going to do a brain imaging or not. And so these are some of the red flags that I can remember and this person have.
Incredible job. Gabby, I absolutely love that, but I don't like it for one reason. And that I don't like it for one reason because Ann Rosa is in love with neurology, and that I want her to be an internist already. So it's going to be a battle between me and you to try to recruit our new friend. That was wonderful. Thank you so much for taking headache, which is like a 2-hour lecture, and giving us such a clear way of thinking about it in such little time. Thank you. Oh yeah. All right, Gabby, the battle between me and you for Anna Rosa's specialty will continue on.
Yeah, I'm ready.
You know, there's so much more to talk about, and so many more people had brilliant thoughts this round, but let's have you all participate with round 2. So I'll come back to Preeti in a moment to tell you that I think we're here. We're in this world of abdominal pain and fever, and we're just going to release the schema on the website very soon. But really, we have abdominal pain and we have fever. So we have abdominal pain plus inflammation. But before we open these two categories, Gabby is telling us that the source of inflammation may be the headache. So we may be in the caveat where the inflammation is not abdominal, it's extra abdominal. But if we assume the inflammation is located inside the abdomen, the tension that T pointed out very quickly is the patient has features of chronic inflammation with fatigue, but the patient also has acute disease. So we may land on a diagnosis just here with the chronic component unexplained. We may land on a diagnosis just here with this process just getting a little bit worse acutely, or we may land on a chronic and an acute complication of something chronic. But if you're thinking about infection in the abdomen, the priority is to think about the 3 Gs, as Gurbani mentioned, acutely, with a rare glance towards non-infectious causes like pancreatitis, portal vein thrombosis, or very rarely familial Mediterranean fever. Chronic inflammatory abdominal pain is also usually infectious, and the infection is either hiding in an abscess or hiding inside a macrophage. But more commonly than an acute disease, you have to think about autoimmune disease. And autoimmune plus abdomen equals IBD, vasculitis, and serositis, with some attention to cancer too, like lymphoma. So there's a lot of unanswered questions here. The first unanswered question is the inflammation in the belly or in the head? And what is the time course of this inflammation? Is it acute on chronic? Is it acute on chronic unexplained? Or is it chronic with acute worsening? We'll have to find out. All right, Preeti, back to you.
Okay, guys, great discussion. I think you are already getting there. So, okay, let me add something in the history of present illness. So, as I said, she has been experiencing this fatigue for last 2 months and occasional headache for last 1 month, actually, and no specific time for the headache. And as I said, she has been experiencing this raised temperature for last 1 month, actually, which sometimes becomes worse at the night. And she has been experiencing this weight loss of 10 pounds in the last 3 months. And she also had this cough with minimal sputum for last 2 months. Also, she has no change in her bowel on bladder habit, no coughing of blood, and no blood in stool as well. And yeah, I think that's all for the HPI. Yeah.
Amazing. Most of the chat was actually trying to pick career choices for our friend from London, but now we focused on TB. And Amanda mentioned TB first, so I'll ask you, Amanda, tell us more about why you think TB might be a good match here.
Cough, night cough, né? And we have weight loss, tuberculosis.
Yes, 100%.
It's very specific and can have abdominal pain, headaches, very common in patients with tuberculosis. And we have 3 months. It's so, I think it's tuberculosis.
100%. Last time you did this, you said lupus. It turned out to be lupus. So I will respect you, even if you say, even if I don't agree with you. But I 100% agree with you. It has to be entertained for sure. Raphael has some interesting thoughts about autoimmunity. Raphael, do you want to unmute and tell us more?
Hi. I just asked on chat if maybe he has some giant cell arteritis, but I didn't remember if this arteritis was chronic or acute. Drew said it usually presents as an acute flare, so it couldn't be arteritis, but it is usually it presents in an older person, so it curses with headache,
yes,
arthritis,
yes,
and fever.
Yes.
So
I think giant cell arteritis is a very important thing to think about here. Anyone who's older the age of 50 who has fever and headache, you have to think about it. And the question is, what is the typical presentation? And the typical presentation is subacute, which the syndrome is. And then the question is, what about the abdominal manifestations? Remember that the correct term, as you said, is giant cell arteritis, not temporal arteritis. And the giant cell arteritis in 40% of patients affects the aorta. So there were initial thoughts from the get-go. It was Kanu, I believe, who mentioned the possibility of mesenteric ischemia. And so vasculitis from giant cell arteritis, essentially aortitis and mesenteric vasculitis is a very important thing to think about here. Kanu, I think you mentioned mesenteric ischemia before. Do you want to elaborate on that thought? Was this with the data we have now?
Sure. So whenever I think of a crampy abdominal pain, there are three things that I always think of, and that is thrombosis, perforation, and obstruction. So considering that we have more history, I would certainly think that it is tending towards a subacute course and a chronic vasculitis with probably an acute event, probably a plaque erosion or an acute spasm may certainly cause these symptoms for the past 5 days that we are seeing now.
Excellent, 100%. Couldn't agree more with you. Danielle, you had a great question about giant cell arteritis that I think everyone should hear. Do you want to just say it out loud?
Yes. Hello, everyone. I'm from Ecuador.
Danielle, tell us, I think this is the first time you're speaking. Tell us more about yourself, please.
Yes, I'm a fourth-year medical student. I recently found out about the CP solvers 3 weeks ago. I've been to maybe 5 or 6 meetings so far. Love them. But yeah, so I was asking whether the arteritis presents with vision loss or has a risk of developing permanent vision loss if untreated.
Beautiful question. So giant cell arteritis, the mechanism of vision loss is ischemic injury to the optic nerve. So it is an optic neuritis that is not autoimmune demyelinating, is an inflammatory optic neuritis. So it is a form of mononeuritis multiplex, essentially, with the two mononeurities being the two optic nerves. So how can that present? It usually presents, most patients have so much prodromal symptoms before they have vision loss. So most patients have a vasculitic syndrome for weeks before they develop the ischemic optic symptoms. But the moment they start to develop symptoms, from the very moment they develop symptoms, the rate of the risk of visual loss is very high. So let me use my hands to articulate it. If this is the time at which somebody with giant cell arteritis is going to lose their vision, they usually have symptoms beginning here. Vasculitic symptoms, not eye symptoms. And they have, fever, headache, not feeling right. And then they start to have visual symptoms here. It feels not right, and boom, they lose visual loss very quickly. So you have some time to quickly intervene on them and make sure they don't have visual loss. So great question. Okay, I'll move us along to tell you that the tension that Teeb, I think, was outlining, is this chronic or is this acute? There's so much more signal for a chronic dimension of this case now. The weight loss doesn't happen acutely. You cannot lose weight acutely. So we know that the syndrome now is much more likely to have chronicity as a permanent part of it. And the question is their acute component really acute, or is it pseudo-acute because the chronic has just risen to the surface? And now we have another tension. The tension is we're also not only getting a signal towards the head with the headache, we're also getting a signal towards the chest with the cough. So we know now we have chronic inflammation, and there are two questions. Is there an acute component to the chronic inflammation, or is it pseudo-acute because the chronic has been building up and popped through? And where is the inflammation? Is it in the head, chest, or belly, or is it all of them? We'll need more data to find out. So Preeti, why don't you give us the data, perhaps medical history, and then the exam as well.
All right, you guys are awesome. Like, you are dissecting every clue I'm giving. So yeah, that's awesome. Okay, so in the past medical history, so the patient didn't have any significant past medical history except hypertension, which is well controlled with drugs, that is hydrochlorothiazide. And she didn't have any history of tuberculosis or any other chronic condition. And okay, and she doesn't have any significant family history as well, but she is a smoker. She is a smoker. She have 5-pack year smoking history, and she is fully active in her daily routine. and doesn't have any allergic history as well to any medication. Yeah. So that would be the, okay, so do you want me go through the physical examination as well? Okay, so let's start with the vitals. So when she came to the clinic, her temperature was 101 degree Fahrenheit and heart rate was 92. Her blood pressure was 130/65 and the respiratory rate was 20. And in the physical examination, the general appearance was looking ill, looking like she was distressed because of the abdominal pain. And she had this non-specific generalized tenderness in her abdomen, like no any specific point of the pain, and no abdominal distension, no organomegaly, and normal bowel sound she had. And non-significant findings in the cardiovascular or the pulmonary examination as well. And the head examination, I would mention, there is no tenderness, and but she had this bruit at the right subclavian area. Okay, and when we did this examination of her eyes, we found that she had this optic disc paleness, pale optic disc. It also looked fluffy as well. The optic disc, it was pale and fluffy, but she had no specific visual problem, no problem with her vision. And the neuro examination was normal with no cognitive impairments, and normal musculoskeletal and skin findings.
Superb. Woo! It just got really, really, really interesting. So let's see where to begin. I'm scrolling up because there were so many good thoughts. Okay. Sorry, I really got lost there. Martine, you had a great question a while ago that I think we should explore before we explore this data. Do you want to unmute yourself, introduce yourself, and ask that question?
Me? Sorry. Hi.
Hello. Oh, I think you're muted.
Yeah.
Oh, no.
Yeah, I have asked from where she is originally. I went where she lives now and from where she came.
Yeah. Where she is will be very, very important. Thank you so much. Primarily driven by, I'm sorry, I just saw Martine can't speak now because he's his family. No worries at all. Thank you for joining us. Teeb, I think that's a great question. It's epidemiology profoundly influences the infections we should think about, because Amanda was alluding to, if she's had exposure to patients with TB, that will change our calculus a lot. And Preeti is just telling us that she is from the United States. So Gurbani, you have an analysis of the optic atrophy. Do you want to just share that?
Sure. So I just think the description of like white fluffy, it like translates to like optic atrophy based on the exam that we were given. And so that's like not a disease itself, but it's more like it's like a clinical sign of something else going on in particular. And so it means that like the retinal ganglion cells are likely affected. And so they can be affected anywhere from along their course to the retina to the lateral geniculate body. And so common like buckets that you can think about are like inflammation, which we've already sort of mentioned before, ischemia, compression, related to increased intracranial pressure, any sort of like nutritional not any sort of like specific nutritional deficiencies, which I don't remember specific ones in particular. Could be like a toxin, trauma, or I would think less likely in this patient, just given her age, of like a hereditary condition. Usually that would be like a childhood condition that would be related to it. And then I guess yeah, that's kind of like a general overview of what I was thinking about.
Love it. Superb. Yeah. We're going to have to use that analysis a lot. We'll use it together after we get input from a couple more people. And Rosa, tell us more about why you asked that question about travel.
So I was thinking more looking at like on a global scale, if she had been to travel to countries like sub-Saharan Africa, where the incidence is quite a bit higher there. So there must have been a higher chance of infection with diseases like TB.
Excellent.
Oh, yeah.
Excellent. That is 100% a very important question, because often when where somebody is born is the question we ask about TB risk, but prolonged residence in places where TB is common is another thing you have to ask yourself. Even if you're starting to move to an autoimmune condition, which we'll talk about in a moment, you have to make sure that you're not dealing with even latent tuberculosis. So that question is really, really important. Though I will say that you can be a little bit more lenient in travel, because long-term exposure is required to develop tuberculosis. So it's not a travel for 5 or 6 days usually doesn't get it. So you really are interested in a travel history that implies long-standing residence in a place with high TB exposure. A really, really good question.
That makes sense. Thank you.
Oh, of course. Okay. So it seems like Kanu is thinking about vasculitis. So tell us more about why you thought that, Kanu.
So there are a couple of findings in the physical exam that I think make me lean more towards the vasculitis. First, I would like to look at the non-obvious thing first, that is the fundoscopy exam, yes. Which shows a pale optic disc. Yes. When I think of the pale optic disc in this setting, it certainly makes me think of optic neuritis or optic neuropathy. Both are actually different. Optic neuritis is usually seen with multiple sclerosis, while the ischemic optic neuropathy can be seen with vasculitic causes as well as non-vasculitic causes. Though I think non-vasculitic causes are a misnomer, because most of them are risk factors of hypertension and diabetes. But the thing is, the optic disc is usually hyperemic, and you can see like cotton wool spots. In the pale optic disc of like arteritic neuropathy that we usually tend to see in vasculitis, the optic disc is very pale, and yeah, that's all. And the subclavian artery bruit certainly makes me think of vasculitis, or at least a stenosis.
Yes.
So the bruit is usually due to a turbulence of the flow of the blood, and it can be a stenosis. Probably not sure if it could be an external compression also, but considering about the other factors, I would certainly think that it makes me lean more toward vasculitis.
Outstanding. I will let that stand by itself. It doesn't need any clarification for sure. Chiara has some reflections too about the bruit. Chiara, do you want to tell us more what you're thinking?
I wasn't prepared for that. But yeah.
We're all just talking.
Actually, yeah. So actually, a bruit just translates stenosis. So an stenosis in a subclavian makes me think about any etiology for a stenosis, most common like atherosclerosis, or like in the scenario of the subclavian steal syndrome. And that can explain maybe that headache, because subclavian steal syndrome can compromise mammary artery, vertebral artery, and axillary. So maybe like in a retrograde flux of the blood can cause headaches or maybe other neurological symptoms. But not so sure how can I explain that abdominal symptoms. So maybe atherosclerosis is having some vasculature compromise in the abdomen. but that's how far I can get here.
Oh, that's perfect. That's brilliant. Thank you so much. And to layer onto that, Catalina has some thoughts about Takayasu. So Catalina, can you unmute, introduce yourself, and tell us that great analysis that you have?
Hi. Well, I was just saying that Takayasu actually tends to appear before the age of 40. In the like diagnosis criteria, it's also actually that it presents before 40 and after 15 years old. So we have to have in mind also like the age of this patient. It would be a typical presentation at this age, although many of the features actually seem like Takayasu, but I don't know how can the age be like fit with this.
Absolutely excellent. Catalina, I think this is the first time I've heard your voice. Do you want to tell us where you're calling from, a little bit about yourself?
I'm from Peru. I'm a 5th year medical student, and I learned of CPS solvers when you did podcasts, because I like to, I don't know, like when I did puzzles or something, I like to hear a lot of podcasts. And I CPS. And then I started entering these morning reports, but I haven't been here like the last 2 months because I was with university, so I'm here.
Yeah, of course. Thank you so much for joining us. It's such a delight to hear you, and I couldn't agree more. I think I just realized I've been talking a lot, so I'll try to summarize where we're at. The part of this syndrome that we cannot argue against is that the patient has chronic inflammation. How? Fever and weight loss. That's chronic inflammation. We've been struggling with the tension of where the inflammation resides because we've had signal of the head, we've had signal to the chest with the cough, and we have signal to the abdomen with the abdominal pain. And I'll tell you that when there's a diffuse localization of inflammation, there's one of two possibilities. I'll say that again. When the inflammation does not localize and appears diffuse, there's one of two possibilities. You have a disease process that is inherently metastatic, like TB with extrapulmonary dissemination to the meninges and to the abdomen, like TB meningitis, pneumonia, and ileitis as an example. That's one possibility. The other possibility is you have involvement of the system or the organ system that lives everywhere in your body. So what is the one organ system that permeates your body from head to toe? The vascular system. So if you have a multifocal disease process, there's two possibilities. Either that disease started somewhere, TB, and went everywhere, or it involves the system that goes everywhere by itself. And we have evidence of vascular involvement in two dimensions. Gurbani outlined that the optic nerve atrophy could be compatible with a vascular process. And then we found a Brui. A Brui is a vascular disease. As Chiara talked us through, a Brui may be because, and Chiara and Kanu both reflected on this. A Brui may be because a Brui is like a wheeze. You know when you hear a wheeze in the chest? A Brui is just like that. The vessel is tiny, just like the airway is tiny. And the question is it tiny because there's something inside the lumen, like an atherosclerotic plaque, most common cause? Is it tiny because the wall is inflamed, vasculitis? Or is it tiny because something is compressing on it? Now, atherosclerotic plaque and compression do not have an inflammatory dimension. So if you say Brui plus inflammation, that should make you wonder about the possibility of vasculitis. But my friends, not everything that is inflammatory that involves a blood vessel is vasculitis. You have to first stop and say, am I dealing with a mimic of vasculitis? Drum roll. These are conditions notorious to mimic vasculitis. Notorious. Most important, endocarditis, atrial myxoma, aggressive catastrophic antiphospholipid antibody syndrome, and a whole list of vasculopathies like fibromuscular dysplasia, segmental arteriomediolysis. Which ones involve the subclavian endocarditis? So we have to think, does this patient have subacute bacterial endocarditis? We have to get blood cultures. But while we get blood cultures, we can think about, okay, if this person has vasculitis, what kind of vasculitis could this person have? And we divide the vascular system into 3 categories: small vessel, medium vessel, or large vessel. The subclavian is a large vessel. And so we're either dealing with giant cell or Takayasu, but as Catalina just told us, Takayasu is exclusive to people less than the age of 40. So we have to worry a lot about what all of you were talking about, giant cell arteritis. And if I'm taking care of this patient, I'm giving her steroids right now for the possibility of giant cell arteritis while we wait for biopsy. The other thing that looms large is a granulomatous infection, but it's too risky now because she has fever, headache, optic nerve atrophy. She could lose her vision today. So I think this case is very concerning for giant cell arteritis. And remember, jaw claudication and jaw involvement is very common, but this is a systemic vasculitis that involves the aorta. And so involvement of the pulmonary artery can irritate the airway and cause cough. And that is a good explanation for cough. 30% of patients with giant cell arteritis have a cough. Involvement of the mesenteric vessels like the celiac vessels, the SMA, can cause an abdominal vasculitis, causing the abdominal pain she has. Another clue to the presence of giant cell arteritis is the presence of an isolated elevation in alkaline phosphatase. That can be isolated alk-phos as a good test. So I'll stop there and maybe ask Preeti to give us the rest of the data right until the diagnosis is revealed. So just before that, and then we'll put our thoughts together.
Okay, wow. So, okay, let's go to the lab findings. So her RBC, WBC, and platelet count were normal. Her hemoglobin count was 13.4. And she had raised alkaline phosphatase, which is 228. Her ESR count was 101, and the C-reactive proteins, the CRP, was 4.2. She had normal findings on her chest X-ray, normal PPD skin test. Her colonoscopy results were normal, and she had negative findings on abdominal and CT, abdominal and chest CT. Yeah, that would be the lab findings for her.
The next aliquot, you'll tell us diagnosis.
Okay, so
Oh,
you want me to do?
no, not yet. Just not yet. Okay,
Okay.
so I'm going to ask my newest and best friend, Anna Rosa. Anna Rosa, please. What do you think's going on? What are you going to put your money on?
I'm really not sure.
Yes, that's the correct answer. You cannot be sure. It is literally impossible. But I'm curious, what are you entertaining? What are you thinking about?
I just don't know, to be honest.
Yeah, wonderful.
Yeah,
No, it's so when you remember this moment, because as a student before you've entered the world of medicine, it might be a little bit easier to say I don't know. But when you become a medical student and then a resident, you'll find that there's so much pressure on you and so much pressure to pretend like you know. And the reason I'm asking you, my friend, is I suspect it's a little bit easier for you to say I don't know than many people on this call who've been through the system of medical school and residency and who have had this like idea that you have to know everything and that you must know it all. So I'm so glad that you said I don't know. And my message to you as you're beginning your journey towards medicine maybe is to never forget how easy it was for you to say I don't know in front of all these people, and to continue to say I don't know despite the pressure that you're going to experience. So thank you for saying that. Thank you. Thank you for saying I don't know and staying true to that and not pretending like you do. And it will get harder for you to do that, but remember this moment and maybe it'll be a little bit easier. I have to tell you for the sake of time that it's not what does this data do for us? This data tells us that the inflammation is hiding because we have not seen it on cross-sectional imaging. What doesn't show up well as inflammation that is hiding? It's in the vessel. When you have endocarditis, for example, and you get CT chest, CT abdomen, you won't see anything. You have to get an echo and blood cultures. Inflammation in the vessel notoriously hides. And so I think this augments the concern that the patient has a vasculitis because we are not able to see it on traditional imaging. So, and along with the isolated elevation in alkaline phosphatase without concomitant biliary disease. This is an isolated alk phos without biliary ductal dilation. The marriage of a negative imaging plus inflammation plus isolated elevation in alkaline phosphatase plus no biliary dilation is very concerning for vasculitis. Now, can you say if you gave the patient contrast, will it not show up on CT scan, vasculitis? Plus, minus. If this CT was non-contrast, the vasculitis can easily hide. The vasculitis may not show up at all on CT scan or may be underappreciated because of its subtlety. So at the end of the day, this is why giant cell arteritis is very, very hard to diagnose, because it can masquerade as fever of unknown origin despite a CT scan. So what do you do here? I think you get blood cultures, make sure it's not endocarditis. You start steroids on the patient, you do a temporal artery biopsy. And if that is negative, then I think you get either an MRI of the chest to look for aortitis or you get a PET scan. But I think you have to really move quickly before this patient might lose her vision. All right, Preeti, back to you.
So yeah, the diagnosis is giant cell arteritis in this patient. So you guys are awesome. Like someone said when I was presenting, I was telling the history of present illness. Someone told the diagnosis at that time. So it's awesome. Okay, so yeah, it's giant cell arteritis, and she was given prednisolone, 60 milligram per day. But she started feeling better actually. But actually, after 3 months, she developed the osteopenia on DEXA scan, and her BP was out of control. So we should think about those things when we are prescribing a medication. And her dose was then reduced to 15 milligram per day, and then we adjusted the dose at 40 and for up to 1 year, and she was doing well on that dose. And we also added bisphosphonate to help with the osteopenia as well. So yeah, that's the thing with this case. Yeah.
You presented it like an expert, and I don't know if you realize it, but how you tell the story maximizes the learning. And I have to tell you, this has been one of my favorite virtual morning reports because my friend Preeti presented it so well, and so many people were comfortable sharing their voices. Thank you so much. Really, it was a wonderful time to spend a great hour with you all. Before I pass the mic to Gurleen to do the teaching points, I really, really want to ask a favor of you all. This community cannot exist without each of you. It is a free resource where all of us get to hang out and nerd about medicine. So please, please take it upon you to spread the message. Maybe tell one friend or one family member or somebody so we can grow and keep getting better at diagnosis and keep, most importantly, making the lives of our medical colleagues easier, and most importantly, by helping our patients. So if you can, spread the word. And now I'll pass the mic to my friend Gerline.
Yeah, so this is a really interesting case. I was just trying to keep up with all the pearls that were shared by everyone in the chat. So in this case, we started off with abdominal pain. So when we were thinking in the beginning about abdominal pain, we're thinking, is this intra-abdominal or is this referred pain? So other things that are outside of the abdomen, like thorax structures like the heart or the lungs, can also lead to abdominal pain, things like heart failure and pneumonia. And then we're always prioritizing the 3 Gs, as Gurbani taught us, about GI, GU, and gynecologic reasons of abdominal pain. And when we're thinking about someone presenting with abdominal pain, you always have to think and consider the life-threatening causes. So those are vascular things such as mesenteric ischemia, abdominal pathology like aortic aneurysms and dissections. Other life-threatening things are perforation. And when we're thinking about perforation, in this case, we were also thinking about it because of the inflammatory nature and the other systemic symptoms with the fatigue, the fever. And then the other life-threatening cause would be obstruction. And then when we're thinking about diagnosing abdominal pain, a lot of times a CT scan is helpful in determining it, but then there's things where a CT scan won't necessarily identify anything. So those are things such as metabolic causes like DKA. Acute pancreatitis is usually a clinical diagnosis that can be made by lab values. Other things that would not be seen on CT scan of abdominal pain would be hernias and zoster. And as we learned in this case, certain types of vasculitis, since we're not visualizing the blood vessels, can be missed as well. And then what it really came down to was collecting the clues. What else is going on? There's abdominal pain, but how do we narrow down and figure out the underlying cause? In this case, the fever and the fatigue brought us into the IMBAID mnemonic of infection, malignancy, autoimmune, drugs, and endocrinopathy. So we knew there was inflammation going on. And then the other aspect was, is this an acute? Is it subacute? Is it chronic? And then the fact that there was fever and fatigue, it could be acute, but then the weight loss made it seem that there's something more chronic and underlying going on. And when we're thinking about the bucket of abdominal pain plus inflammation, we're again thinking about the time course. If it's acute, we always want to prioritize infection. That's something we don't want to miss, but other things to consider would be things like pancreatitis, portal vein thrombosis. And then when we're in the realm of chronic inflammation and chronic abdominal pain, we're thinking about infections as divided into things that are causing abscesses in different parts or things that affect the macrophages like TB we were considering. And then other aspects for chronic would be autoimmune like vasculitis or serositis, and then obviously cancer and malignancy. And when we're looking through these different causes, looking at the epidemiology with base rate of disease, where the patient is from, would help us figure out infectious that would be endemic to those areas. The other aspect where we're trying to hone in on is, where is this inflammation? Are we able to identify where it is? And in this case, it was more multifocal. So when we're thinking about multifocal inflammation, we're thinking about, did it start from somewhere and then did it spread like TB or metastatic disease? Or is it involve the vasculature, as the vasculature is all over your body? And then the other aspects that we kind of touched upon were headache, thinking about primary versus secondary, looking for red flags. In this case, the optic atrophy as well as the systemic signs made it more likely to be concerning. When we're thinking about optic atrophy, thinking about, is it inflammation, is it ischemia, is it compression, or are there other things like nutritional deficiencies or trauma? In this case, what really allowed us to kind of put everything together were the associated things. So there was the subclavian bruit. When we're thinking about bruit, is it atherosclerosis, is it due to compression, or is it vasculitis? In this case, the different clues kind of pointed towards vasculitis. And then when we're thinking about vasculitis, it's small vessel, medium vessel, or large vessel. In this case, the subclavian artery is a large vessel, so we're thinking about either giant cell arteritis or Takayusu. And as everyone in the chat and everyone contributed that, you're thinking about the illness scripts. Who is it more likely in? What is the clinical syndrome? What are the associated signs? So Takayusu arteritis is more common in people that are less than 40. So in this case, giant cell arteritis, we had our hypothesis was stronger for giant cell arteritis as compared to Takayusu. And then when we're thinking about giant cell arteritis as a whole, the jaw claudication and the initial vasculitic symptoms are present, but then obviously the danger is in the optic atrophy and the blindness that can result later on. So that's why it's important to diagnose it early on. And then an interesting pearl that I didn't know about was the isolated alkaline phosphatase elevation with giant cell arteritis. That's isolated, so there's no bile duct dilatation, but it's isolated because of the associated arteritis, as well as cough that can present because of irritation of the pulmonary artery. So thank you so much for joining us, and hope to see you again soon.
Bye, everyone. See you soon. Also, bye from Nar, who's feeling much better for those of you who have been around. He has recovered from his transient illness. Bye.